Hello, everyone, and welcome to Investor TV. A $200 billion pharmaceutical supercycle is already underway, reshaping how tens of millions of people lose weight. But what if the biggest investment opportunity isn't the drugs themselves? What if it's what happens after? Across clinics worldwide, physicians are now seeing something unexpected: rapid weight loss triggering structural changes in the body, loss of facial volume, skin laxity, and deeper tissue shifts. And here's the problem. The tools we've relied on for decades in aesthetic medicine were never designed for this moment. So today we are asking, is the GLP-1 revolution quietly creating an entirely new category in healthcare, one that could redefine the future of regenerative medicine and potentially reshape how we think about aesthetics, longevity, and even metabolic health itself? To explore that, I'm joined by three extraordinary physicians working at the forefront of this shift. Dr. Jennifer Pearlman, an aesthetic and regenerative medicine physician focused on advancing treatment strategies and whole patient approaches to aging and metabolic health. Dr. Claudia Chavez, a plastic surgery, burns, and wound healing specialist with deep expertise in tissue engineering and regenerative reconstruction. And Dr. Sabrina Fabi, a cosmetic dermatologist and clinical investigator involved in more than 175 trials, bringing a frontline view into how patient demand is evolving in real time. Thank you all for being here today.
Thank you for having us.
It's a true pleasure. So let's start at the macro level, because this shift is really bigger than aesthetics, as I mentioned. So Dr. Pearlman and Dr. Chavez, we're looking at a drug class projected to reach $200 billion by 2030, with tens of millions of patients now using GLP-1 therapies. So when a platform of this scale begins to reshape human physiology globally, what does history tell us happens to the industries that really sit around it?
I can jump in there, Ashley, as someone that has been part of the GLP-1 story for a long time. And I can say that we're still in the early stage of the transformative effects of this platform technology. So, like you've introduced so eloquently, if we think instead of this category as a platform and not a drug category, we'll really deeply understand the global economic impacts and the trickle down and up effects across certainly all of health and aesthetic medicine. We already see this, whether it is the pleiotropic or side benefits across the, human physiology. And we certainly see the impacts on, as you said, the aesthetics, the hair, the skin, the face, and the body. And it's already shaping industries beyond healthcare and aesthetics. After you've lost 2 sizes of weight, you're out there buying a new wardrobe. And with the reduction in appetite, on average, this is 30-40% for users of GLP-1 medications, we're seeing less intake. And almost every major food company has mentioned this, as of the big fashion houses, when they're communicating with their investors and audiences. So this really is a transformative technology. We're in our early stage. I like to say the GLP-1s are a gateway to this new era of metabolic medicine.
I like the way you phrase that, a gateway to this new era of metabolic medicine. So I just have a follow-up. Is this a healthcare story, or is it something much broader, potentially reshaping multiple sectors of the economy?
I think it's both, Ashley. I think it's transforming human health and healthy longevity. It already is reshaping every aspect of medicine. I mentioned a few, and within the aesthetic industry itself, whether it's the new issues that are arising for users of the medications, individuals that are experiencing rapid weight loss, and the new paradigm with which practitioners are approaching their patients, in the sense that, especially in aesthetics, we're seeing a new demographic. GLP-1 users by majority are new to aesthetics. So a lot of education, a very strategic, structured, sequential approach, and one that embraces a paradigm shift in how we approach the skin.
Yeah, thank you for that. I like how you bring that up, how they're kind of new to this space because they're not the typical ones that are going in getting the, monthly treatments or tri-monthly treatments, whatever it is. And I know that, you both, Dr. Chavez, Dr. Pearlman, you spent decades at the intersection of women's health and regenerative aesthetics, and you're now seeing this shift arrive in your clinics in real time. Beyond the headlines, though, what is actually happening at the patient level that the market hasn't fully, caught up with yet?
Well, I'm going to intersect here. So I think what's happening is we're seeing more and more patients that don't want to have the mask face, don't want to get the products that have been there before. They want to have a more natural look. They're talking about regenerative because regenerative is up in the headlines everywhere. We were just at MCAS last January, and you can see that every single pharmaceutical company is actually, highlighting regenerative. We see it even in our face creams and, and everything that we have around us. Everything regenerates. Skin, your body, your gut health, everything, right? Everything regenerates. So we're seeing that more and more. Now, these patients want a more natural look. Now we have, as Dr. Pearlman was saying, we have this new patients that have been on GLP that are seeing some side effects like losing, their fat in some areas that, they didn't want it to lose fat in those areas, right? And now they're coming into the aesthetic clinics trying to find some kind of solution. Now, I would say, are we there yet? And that's, I think, another big, question for debate, because what we have right now, we have certain tools that we can help them aid in those kind of more volumizer tools, I would say. Yes, we do have the branch or the vertical of biostimulators, but we're not in the regenerative space yet. See? And before we actually go into that regenerative space, I would have to say that we have to really understand what is the biology behind it, right? What is this GLP actually doing to our patients? What is it doing at the cellular level? So at the adipocyte part, how are these cells interacting? Because if we want to regenerate this tissue, we need to first understand what's happening in the cells to be able to actually come up with a treatment or a solution for these patients that can be long-term. Otherwise, what we have right now is volumizing tools, or we have some what we call biostimulatory fillers, that what they do is basically they stimulate our body through an inflammatory reaction. They stimulate our body to produce collagen. Now, if we don't understand the cells, maybe those cells are not even going to be able to produce that collagen. So these are the things that I think we really need to go back, rely on our science, right? Mm-hmm. Get back to the books, get back to understanding what the cells are doing. And then we can probably come up with a solution, right, for these patients.
Excellent point. That's the research right now that's underway. I would have to imagine that is paramount to understanding everything about GLP-1s and what's happening in the body. And, as Dr. Pearlman mentioned, we are seeing data that more than half of these patients have never even engaged with aesthetics before. And that suggests that it isn't just incremental demand, it's an entirely new patient population, pretty much. Who is she, and is the industry really ready for her?
I could add, just for my experience, sort of at the intersection of holistic health, women's health, and aesthetic medicine, I would say there's 4 important themes to build on what we've heard from Dr. Chavez. And that would be this. I think first and foremost is that most obvious, I know some have coined it Ozempic face, and it's clearly not the medication alone, but rather the facial sagging, and the idea that our patients don't want to trade their bulge for the sag. So the volume loss, the hollowing, the facial sagging, this is a new, emerging, frequent indication or issue that our patients bringing into the clinic, but it's tip of the iceberg. And it's up to us to educate, partly because a large majority of these, about 2/3, are new to aesthetics. My second point, and that is that alongside the hollowing and the sagging because of the loss of facial fat, we're also seeing aging of the skin. And this is architectural deterioration of the skin itself, and something that ultimately needs to be addressed early and dealt with that holistic, that word you mentioned, Ashley, regenerative approach. And, it's something that the earlier you start, the more proactive you are, the more integrative you can be with our tools, the better we can help our patients not address that skin aging effect, but rather mitigate it in the first place. After all, there's GLP-1 receptors on fibroblasts, the mighty cell type of our skin that upholds its regenerative capacity. My third point, you mentioned this too, Ashley, is the uniqueness of our women. I mean, very passionate about this, but women do make up the vast majority globally of the demographics seeking these treatments, both aesthetically and on GLP-1s. And we're seeing the demographic from, let's say the 40s to 60s that traverse the menopause transition have this tsunami, the double whammy of estrogen depletion and the GLP-1 mediated depleting effects hitting their skin simultaneously. We need to be mindful, and we need an estrogen mindful approach to prevent that tsunami. And my fourth point would be something that for many is still unknown and certainly surprising, is that there are many off-face targets of this GLP-1 effect. And, your intro, Ashley, talked about how widespread this is, but the impact that I just discussed on the face and the skin is also felt at the level of the hair follicle. So the depletion of the stem cell capacity to uphold healthy, glowing hair, the effects on the body, even the pelvis, we are seeing full body off-face effects that we want to be mindful about. And, really in a very sensitive and strategic way, address with our patients who, as we said, they're new, they need more education, and they also, they have some fears around perhaps some of the legacy treatments that were, or approaches that were such a big part of aesthetic medicine.
So important that you bring that up. When you talk about the metabolic health, menopause, longevity, it doesn't really exist in isolation because of everything that you're saying and what you're seeing coming into your clinics. Dr. Fabi, when these patients come into your clinic, what are they actually saying? What are their concerns? And how open are they to treating those concerns?
It's interesting. I have a pretty closed practice, so it's my established patients that I would be seeing. And some of them don't really share that they're on this medication all the time. I'd probably say about 50% are open that they're on it. And then I sometimes have to do the questioning because I see the changes that are happening with their skin. They're a little bit more lax. They have unique volumetric changes, specifically around the temple area and then around the eyes, which we know are preferential areas where this fat tends to affect the face, giving it a particular look that you may not necessarily see just age related. And so in a 30-year-old or in a 40-year-old, when you hit a tipping point and you've lost too much weight. And so then it prompts the question for me, do you happen to be on a GLP-1 agonist medication? And then they'll say, well, actually, yes, I have been. I lost 20 pounds or 30 pounds or 40 pounds. But that's usually a cue for me, as well as their skin just not looking as youthful as it once did. And so it coincides with a survey that was done globally by one of the companies, aesthetic companies, where they surveyed over 1,300 women in 3 continents to determine how many of them recognize the facial changes and how many of them, to Dr. Pearlman's point, would now be an aesthetic considerer, which previously would not have been an aesthetic considerer because they weren't as body conscious, but now they are. And in that survey, what we found was that over 50% of them would now be aesthetic considerers. The number one thing that they noticed was a loss of facial fullness, and secondary was skin laxity. Which is interesting because that may not be something that we necessarily see in someone until perhaps their later 40s or 50s, but now they kind of pull at their skin and there's an obvious laxity, especially underneath the chin, that you may not necessarily see correlated with their chronological age. And then maybe the last thing would be lines or wrinkles, but not as much as fullness and laxity. And then in that same survey, a third of them would have done something earlier to prevent their change had they known that they would have experienced these face and skin related changes. They just aren't coached about that when they're prescribed these medications. And in some countries, you don't necessarily even need a prescription. You can go to a pharmacy and get it yourself. So there's a lack of awareness and a gap that exists to educate people about, to what Dr. Pearlman had mentioned, the more holistic and global effect that these medications have, not just weight, but then the impact that that lack of or loss of superficial fat then has on the architectural support of the skin. And then, of course, the stem cells that reside in that fat and their effects on the skin.
Yeah, which can actually be very dangerous when you think about it. Dr. Fabi, I'm glad that you mentioned that even, patients that you've had for years aren't outright about the fact that they are taking it. Why do you think that is? And what would be your recommendation? Because, it is scary to think that they didn't get the education perhaps, and that, this could affect them in the future if they're not well educated, and maybe you should be more upfront about it so that you can help.
I would probably say that people want to feel that they did the weight loss themselves. Maybe there's a little bit of shame around having to take something to help you with that weight loss. People want the badge of honor of having lost the weight. And I understand that psychologically. The thing is that this is a drug, just like any other drug. You need to report it to your doctor because it can impact drug interactions, or it could impact, in this case, the way that you may respond to certain treatments. In a recent study, to Dr. Chavez's point, trying to understand what is happening at a biological level. We just recently presented this in Monaco this year, but we're doing one of the first trials to actually prove that at the cellular level of the skin, GLP-1s have been shown to inhibit stem cells, specifically the adipocyte-derived stem cells, that support and that ultimately differentiate into the fibroblasts that create collagen, elastin, and hyaluronic acid at the skin, which then participate in the lines, wrinkles, and dryness that some people may report, as well as laxity. But they also participate in new healthy fat cells at the level of the fat that support the skin, and that are also the engine where perimenopausal women and menopausal women may get some of their estrone or estradiol, their hormones that now they have to lean in on because their ovaries aren't producing it like they used to, that also support cellular health. And so this is new. And with this understanding, we understand now why we're seeing these rapid accelerated facial changes and skin changes specifically in this demographic.
Yeah. So Dr. Chavez, I'd like to ask you, what your thoughts are about why traditional tools like fillers, injectables may not be designed for what we're seeing now, sort of, in parallel to what Dr. Fabi's talking about.
Yeah, and I think that, again, it goes exactly to what I was exactly saying. We have to understand better, right? So knowing obviously, and I have read that study, Dr. Fabi, and that's why I was trying to say, this is not that with what we have, the tools that we have, we can solve. This is not a problem that we can solve with the current tools. We need, if stem cells, as Dr. Fabi is saying, if stem cells are actually damaged, right, and they're not responding anymore to adipogenesis, for example, which is what she was mentioning, promoting again fat in specific areas, the fibroblast not being able to, produce more extracellular matrix, then we have a problem, because now you're talking about you have to come up with a cellular therapy. Now you have to come in and implant or inject cells or other drivers or signals that will again activate those cells and make them produce what they're supposed to produce, either extracellular matrix in the case of fibroblast, or in the case of the differentiation of adipose-derived stem cells into adipocytes, right? So all these things we have to be sure exactly. And again, there's not only one pathway that gets damaged or blocked, right? There's other pathways that can be also damaged or blocked. So those are the things that we really need to study. We need to really make sure that what is it that we're seeing? What is the factor that we see? Not only the laxity of the skin and all that stuff, right? We have to look at the cellular level, the mechanism, and then we can come up with a solution. So right now, if you ask me off the bat, what would be the solution for this? Well, I just said it, like we would have to rely on cellular therapy, or we will have to go into exosomes, for example, or signalings, right? That will try, and this is, again, in vitro studies that we would have to do in order to make sure that we were able to activate these cells again. And hopefully just locally, because what you don't want to do, because this drug acts systemically, right? And what we would like to do is, again, activate the cells at the local part. We don't want, again, systemic to have, again, this patient will go, again, fat, will become fat. Maybe would have metabolic, issues as well. So that's not what we want to do. We want to just, kind of activate the cells at the local site. So then these cells can produce, again, fat pads. We can produce extracellular matrix, that kind of thing. So it's completely new. We're not there yet. We're trying to, again, as Dr. Fabi was saying, we're looking at what are these consequences. And once we understand the consequences, then we can think about, okay, what's going to be the solution? But currently there is no solution.
Right. So would you say, anything has really changed scientifically that makes this different from the past waves of promise with these kind of drugs?
Yes, absolutely. Right. And again, now people are getting more access to, or having more access to, GLP drugs. Mm-hmm. Either the Ozempic, we're coming now, well, in Canada, we already have it, like the tablet, right? So the oral GLP-1, right? So, and we see advertisements all the time where it says like, oh, join this whatever club, or I don't know what it is, like through the pharmaceutical, and you can get it for $99, right? So you get a month treatment for $99. So it's getting more and more accessible. So more patients, and some of them are auto prescribed. It depends. In Canada, it's still under prescription, but there's other countries, as she was saying, like, that you can go and get Ozempic. So then people are even traveling and getting the drug and then bringing it back to their home countries and then just having access to it. So it is something to be aware. Now, GLP has many benefits, and I think we've talked about it last time that we kind of met. Yes. We should recognize too, but I think, as we said, I think what we have to do, and this is our labor as physicians, is like we really need to educate our patients. Mm-hmm. 2, there's specific criteria where you should put the patient on GLPs or not GLPs, like it's not like for everybody. It shouldn't be something that everybody takes and then just because I want to lose weight, okay, let's do it. It's not about that. It has to be very well regulated. We have to educate our patients. There's side effects to it. There's benefits, but there's also side effects. So again, I think that's our labor, and we should do that all the time.
Yes, absolutely. Dr. Pearlman, I'd like to ask you, just to maybe piggyback off of this and talk about some of potentially the benefits of the GLP-1.
Yeah, I think picking up actually where Dr. Chavez left off, when prescribed and employed within a physician-patient relationship, so there's a trusted guide, there's a personalized approach with a science-informed, strategic, and progressive journey that is designed around, in medicine, we talk about their indications. We know what we're targeting. On label, these medications are approved, and this is true in every geography, they are approved for diabetes and obesity. And I will tell you, in my practice, 0% of my patients that I am prescribing these medications to fit that mold. We are using them as optimizers where there is metabolic dysfunction, whether that be insulin resistance, fatty liver. We have good data to show that these medications synergize well in that menopausal cohort for women that have experienced, as so often women do, metabolic changes as part of their menopause transition. As an aside, on average, women gain 1 to 2 pounds per year of transition. That's 7 years. Do the math, 15 pounds. They're not obese, they're not diabetic, but they're metabolically unwell. And with comprehensive assessment, my biomarkers show this to me. They tell me their body shape change. And with AI sophisticated tools, and even our regular tools that we can use in the clinic to see their body composition has changed, such that we can really optimize their metabolic health, their body health. The idea that we don't want to exchange bone and muscle for fat, which happens with that insulin resistance of midlife, and for women, very much with menopause. We can prevent and treat fatty liver. And we know, actually, well scientifically established, we call them the side benefits, the tropic effects, kidney protection, heart protection, and still emerging, the idea that this platform, this class of medications may well put a dent in a set of conditions, let's call them the neurodegenerative diseases or Alzheimer's disease, where we still, through medical management, have barely made a difference. So I do think the future is very bright. I practice within a realm, we use the word longevity, and I think beyond all of these indications I mentioned, the chronic diseases of aging, the indicators of risk to those diseases, we also, in this world of longevity medicine, have at least an inkling that beyond improving health by these means I've described, that perhaps this class of medications may actually extend human health span, the years of healthy living. And it is my belief that likely this will be driven beyond, of course, the direct effects for those who need it of the weight loss.
Fantastic. Dr. Fabi, with all of the trials you've been involved with, would you like to add anything to Dr. Pearlman's comments on this?
Yes, I couldn't agree more with Dr. Pearlman that it would make sense by decreasing the glycemic index, or that the glucose that sits or spikes after you've ingested a meal, and the deleterious effects that it can have on inflammation and many of the cellular cycles of aging, many of the different hallmarks of aging, from potentially increasing inflammation, decreasing autophagy. That's basically where the cells are able to clear up some of the zombie-like cells, or cells that are no longer working like they should. Probably there's no drug that addresses more of those pathways of aging than this drug. But yet, we see these changes at the level of the skin. The skin, that's my bias as a dermatologist, is what you're able to actually visualize. You can't see the heart, you can't see the liver, you can't see the brain, but you can see the skin. And so it sometimes offers us a window to be able to gauge what it's actually what something is doing. It's an indicator of systemic disease sometimes, because it's our largest organ and it's an organ that's visible to all of us, right? And so to see some of the rapid changes that we see in aging of the skin also sometimes for me makes me pause and wonder why a medication that theoretically should have all these benefits is having these changes too. And so that's some of the work that we're doing right now, measuring and quantifying mitochondrial health markers, because theoretically it should have an impact. We would hypothesize that it has it, but no one has actually done the research to prove it. It should decrease cellular senescence. This is where your cells no longer function like they used to and churn out like they used to. So they're just kind of sitting there like dead, and releasing mediators and messengers that signal to the rest of the cells in your skin to not work like they should. And so we're measuring those markers as well. So this year, we should have a greater understanding if what we hypothesize should be true at every cellular level is actually true, because we really don't know. And so with that, then we can strategize what type of intervention would make most sense for an individual. We know, and work and studies that we've done in my clinic, that certain lasers can decrease cellular senescence. So if cellular senescence is an issue, then perhaps a laser would be appropriate. We know that injectable PLLA has been able to show a 2 times increase in adipocyte stem cell stimulation 6 months after the last injection. So if we are now seeing that there's a decrease in this population, well, now we have an injectable that could potentially target this stem cell population. So truly understanding what's happening can then guide and inform treatment algorithms.
Yeah, incredibly important research underway right now. Thank you for explaining that. Dr. Chavez, we're also hearing more about biostimulation materials. They don't just fill space, but they signal the body to regenerate, as we were talking. What are those signals biologically, would you say?
Yeah, so I mean, the biostimulators, yes, they do signal. What it really happens is that they produce an inflammatory response.
Mm-hmm.
They act as if they were a foreign body. So the body doesn't recognize it as own. So all the inflammatory cells go in. There's a lot of, signalings like TGF beta and a lot of other things that, they're basically alluring other cells to act, right, and respond against this, because that's what it's happening. You're responding against what was injected. And I mean, yes, by that mean, you are making the cells to act more, in this case, fibroblasts, and then to produce more extracellular matrix. Now, is this extracellular matrix mature? No. At the beginning, it's going to be just an extra, for example, speaking specifically about collagen, it will be an immature form of collagen, right? What they start producing. But eventually, what it can happen, and this is where we have to be very mindful about who these patients are supposed to get, or how are you going to treat these patients, right? So fibrosis can be one of the deleterious or side effects of having biostimulators, right? You can get granulomas. You don't know what the inflammatory response is going to be for each patient. Each patient or each person, we react differently, right? I can get a biostimulator, for example, and not have any inflammatory response, or have some inflammatory response, right? I'll get collagen activation, and that's it. But there's other patients that could be very sensitive, and not sensitive against, it's not an allergic reaction. That's not how you should think about it. It's more like their body is more prone to mounting an immune response or an inflammatory response that is going to be heavier than other patients, right? And so they start producing, fibrosis. They can get encapsulate, for example, these fillers that we're placing in. So I think those are the things that I wanted to talk about biostimulators. But yes, that's what exactly they're doing. They're stimulating. It's a foreign body. It's a mount inflammatory response, right, against that foreign body. They're trying to basically clear it because it's something that is not supposed to be in that part of your body. And then by those means, fibroblasts are producing collagen or other proteins from the extracellular matrix.
That's great. I was just going to follow up on that and ask about how close we are to smart biomaterials, materials actively responding to the body to guide healing.
Right. Healing is a big, controversy. Well, not controversy, but I think we talk about regeneration, right? And our body, to tell you the truth, our body doesn't regenerate on its own. We have a specific organs or specific tissues that actually are able to regenerate to a certain extent. So, for example, muscle, if it's damaged for 20%, well, it's able to regenerate. Liver is another one that, if it's just 20 or less than 20%, it's able to regenerate. Although we always see, if it's more than that, we will see fibrosis in that wherever it was damaged. So we don't tend to regenerate. Okay, we may have the capacity to do that, but we have to help the body to do that. The body doesn't regenerate on its own. So, and what do we talk? What is really regeneration? Because this is again another, it's right now in fashion. People use regeneration as as something that it's miraculously happening. But regeneration is basically if a tissue is damaged or lost by whatever reason, right? Our body or what we're doing is replacing it with exactly the same tissue was there. Okay. Everything. And not only it has to look like it has to function as it was functioning before. So that's regeneration. It's like the salamander is the most typical story, or not story, but it's the typical definition of regeneration, right? You chop a limb of a salamander and the limb grows back again. Mm-hmm. Exactly the same as the limb that it had before, with the same function. All fingers will wiggle and move, and the nails will grow, and everything is exactly the same. That is regeneration. That is true regeneration. Now, as I said, our body doesn't have the capacity to do that. We're trying to understand more and more our body to see how we can aid that body to make that happen. For example, we know that for every single tissue, every single organ, we have three major components, right? We have the cells, we have the signals, and we have the extracellular matrix. In the past, we thought that the extracellular matrix, all it was just to support the cells. Now we know that it actually regulates the behavior of the cells. So it goes beyond that. We know that extracellular matrix, for example, plays a key role in cancer. it's actually regulating the cancer, like the cells to actually become more, not become cancerous, but at the same time behave the way that they're behaving, just proliferating and proliferating, right? So we know now that the extracellular matrix it's not just like, a building. It has way more activity than just being a building where people live. Mm-hmm. And in this case would be the cells as an analogy. So as we're understanding that, and we're understanding how are they, regulating the behavior of the cells, as we're understanding how the cells also are signaling. Signaling is basically the communication between cells to cell. So cells communicate with other types of cells or with the same types of cells. And the way they communicate is like us right now. We're having a conversation. I'm talking, you're listening, we're comprehending, right? The cells is the same, two of them, but instead they don't have a language. Their language is actually throwing out signals. So for example, they throw some kind of, molecule to the other cell. The cell catches the other molecule and in response throws another molecule to it. So that's how we see now how cells behave. Now the extracellular matrix has these pockets, like these binding spaces, where it has the capacity to basically pick up those signals and retain them. So when other cell comes by, it knows exactly how to behave. So it's like there's cues, right? As you're walking, it's like, imagine like the traffic signals. Right? So when you're driving, it says stop. Well, you stop, right? You don't go through. So it's the same. Like the cells will know exactly if they have to migrate, if they have to proliferate, what is kind of that behavior happening in there. Also, again, as I said, like the cells are actively communicating. And ECMs are not just a passive mechanism, it's an active mechanism. So the whole environment is so complex, actually. It has taken us like decades and decades and centuries to really understand it. And we're not even there yet. We don't fully understand. We're always like seeing more and more things. We're understanding different mechanisms, different pathways. And the reason why is because it's an active situation. Mm-hmm. It's like all of us talking at the same time. And unless somebody's like really focused on one specific niche, right, and trying to really understand how all the players are, communicating or behaving, it's hard to really understand the whole, right? And it gets more complex when we know that, through our bloodstream, there's more signals that travel through that come from distant. It could be from, your liver coming into your skin. So, and then that it becomes way more complex because even when we try to just study a little niche, right, to remove all the many variables, we're trying to understand that. But when we think that we understand that, then it comes something else, right? Oh, the liver sent messages to, okay, well, it wasn't even distant. Like it wasn't even close enough to think that probably the liver was doing it, but yes, it does, right? And then now we have drugs again, right? So those drugs also get metabolized in our body. Things are circulating through our body. And those are also signals that, are telling the cells how to behave and what to do and what not to do. So it gets really, really, really complex. But the truth is, we're doing our best to understand what's happening. As we move forward and we try to understand more and more the complexity of our body, we're able to come up with better solutions, with more like smarter, we call it smarter solutions, but really is aid the body. Our body's really smart. And it's us sometimes that we're taking things that we're not supposed to take or eating things that we're not supposed to eat or having behaviors that probably we're not supposed to do and, damaging our body, but yet the body is able to recover those things, yet is able to, even come up with different pathways or different ways to actually make it better, right? So it is a complex environment. I think as we understand it, as I said, I just want to remark that, we're able to come up with better solutions and aiding the body. That's all I think what we try to do here.
Well, I wanted to pull together some of the really astute, wise comments from my colleagues, Dr. Fabi and Dr. Chavez, that were just shared over the last several minutes. First and foremost, that the skin is a real biomarker of your biologic age. And obviously, Dr. Fabi, as a dermatologist, has a deep knowledge of how much is reflected in the radiance and appearance of the skin. And I think we should be mindful in aesthetics. What we're seeing is a correlate to what's going on biologically throughout the body as well for patients on these GLP-1 journeys. But that brings me to the second point, and this is something I feel very strongly about as an integrative, holistic, strategic practitioner, physician working for so long with patients, is that for the most part, GLP-1s are being prescribed wrong. And as has been said, in many markets, they're not being prescribed. They're just merely available. And we need to fix this issue. So when used in the right patient for the right indication with the right strategy that has both an integrated plan and an off-ramp at the inception, an off-ramp to a maintenance dose or a discontinuation, they can be transformative, but there are deleterious effects. And in aesthetics, we are certainly seeing it, as has been discussed. And this, of course, brings me to the third point that Dr. Chavez has elaborated in, which is that we as practitioners, as physicians, as scientists, need to put on a new hat. And I think that is one of an engineer and an architect. We need to solve this problem really with a robust strategic approach that is architectural in nature and builds from the foundation up with a new arsenal, a new set of tools, which I could share the words of Dr. Chavez is perhaps not actually regenerative, but part of restorative aesthetics. And that for me is incredibly exciting. The future is not only bright, but I do think that more patients than ever before will know vitality, beauty, health, and powerful aging in ways we're still at the early stage of understanding.
Yeah, it is not just about aesthetics, as you said. It's certainly about a broader transformation in medicine, treating symptoms, restoring systems, repair to regeneration. As GLP-1 adoption continues to scale globally, the downstream effects may create entirely new categories of demand and opportunity. Dr. Pearlman, Dr. Chavez, and Dr. Fabi, thank you so much for your expertise today. We certainly appreciate it. I'm Ashley Berry, and this is Investor TV.